Ken, would you like to start your patient?
Yeah, thank you very much. So, okay, so I'd like to present my cases. 55 years old male patient, and the tumor, he has presenting the hoarseness and the dysphagia. And the endoscopic revealed the tumor, type 2 tumor on the upper side esophagus. And the biopsy reveals the squamous cell carcinoma, and there is no lymph node metastasis and no weight loss. And the CT shows adherence to the trachea, and the primary tumor closely related to the trachea. So maybe that type B cases. And what to do manage plans? Esophagectomy, definitive chemoradiotherapy, and neoadjuvant chemoradiotherapy, or neoadjuvant induction chemotherapy, or not?
Question was for me. Yeah. Is that right? Okay. Then I would decide in this case for definitive chemoradiotherapy.
Chemoradiotherapy, okay. Yeah. Okay, so maybe this is the T4B case, and as you mentioned, the definitive chemoradiotherapy is the standard of care. I know that, but our MDT team discussion. So firstly, so we do the induction chemotherapy by the DCF. So because for example, the head and neck cancer, the induction chemotherapy using the triplet regimen, 500 cisplatin and DCF, shows more than 1,700 of the response rate. So if the tumor shrinked after the chemotherapy and the restaging was done, and if the resectability was shown, so the surgery surgeons would be there are some chances to esophagectomy. So it is an unusual case, but okay. So this is a result of the pause. So of course, the definitive chemoradiotherapy is the standard of care, I think. Okay, so how do you think about the diagnosis for the T4B? Simon, how do you think about that? Okay.
Normally, with that sort of tumor, we definitely would do a bronchoscopy just to make sure that there's no tumor invasion. Knowing that if it's true tumor invasion into the bronchus, if you give chemoradiation, there is a high chance of fistulation. I presume that you've done one and there wasn't any bronchial invasion. So in our center, we would probably give chemoradiation first. Having said that, in some patients, we do give induction chemotherapy, especially in patients with metastatic disease as well, and partly for logistical reason, because in a public system in Hong Kong, radiation needs planning and the waiting time is quite long. So in advanced cases like that, for logistic reason, if we want to start treatment as early as possible, we would start with some induction chemotherapy while the radiation planning is going on.
Okay, thank you. So, and we have a data for the 20% of the fistula formation is observed with chemoradiotherapy with the T4B disease. So sometimes we started from the induction chemotherapy and followed by chemoradiotherapy, and then we started 3 courses of the DCF therapy. And no significant adverse event was seen, and the oral intake was improved. But the endoscopy showed the residual disease after the 3 courses of the DCF. And the tumor was shrinked, but obviously the residue and the T4B was not improved, and the trachea's adherence is remained, and still the no metastasis was seen by the PET scan. So we decided to move to the definitive chemoradiotherapy with a 5-FU cisplatin plus 60 gray, which is the definitive dose in Japan at that time. And the additional field set the 3 centimeter and upper and lower from the primary tumor. Okay. And then after the chemoradiotherapy, the endoscopy shows the complete response, and the primary tumor has become a scar without biopsy pathological negative. And the CT scan shows slightly more thickness, but it not obvious tumor shape. And after 4 months, the CT revealed the right cervical lymph node metastasis, and the CT PET scan uptake in the C in the right cervical lymph node, and weak uptake in the primary tumor, but the endoscopic shows no obvious thickness of the esophageal wall. Okay, what do you management from? So, okay, could you poll the vote? The esophagectomy plus lymph node dissection, and only lymph node dissection with adjuvant chemotherapy and the definitive chemoradiotherapy and chemotherapy or best supportive care. Okay. In gross trachea. Okay. Okay, could you see the vote? Okay, most of the cases are lymph node dissection and or esophagectomy. Okay, the diagnosis of the recurrence of the primary site is very difficult. So Daniela, so how do you think about the weak PET scan on the primary site and the endoscopic feature?
So I think that in this situation, it's very key, as some of the attendees have mentioned, to do a bronchoscopy to see if there is tracheal invasion. So if there is tracheal invasion, tracheal invasion doesn't go away with chemotherapy alone. So I would not resect a patient that has tracheal invasion. But I would not also treat with chemoradiation up front if there is tracheal invasion because of risk of fistula. So if there was positive tracheal invasion, then I would definitely give chemo alone, followed by chemo RT. So in this situation, I probably give him chemo RT because he had a good response to chemo and there was clear invasion in the trachea, although we don't know the bronchoscopy result.
Yeah, thank you. There is a possibility to still the adherence for that bronchus is the very good point, I think. And but I recognize that this is not recorded in the primary site, and only the lymph node metastasis exist. But I think that the period from the chemoradiotherapy is too short, because only the 6 months after the 4 months after the definitive chemoradiation, the recurrence was occurred in the cervical lymph node. So we decided to the chemoradiotherapy for the cervical lymph nodes because there is some possibility to recur not only for the lymph node cervical lymph node, but the systemic metastasis. So we would like to do the systemic therapy for these cases, and our radiation oncologists show they can do the radiotherapy for the cervical lymph node by VMAT technique. So the radiation fields are very close to the FORMAT field. But we go to we do the definitive chemoradiotherapy with the 5FU plus cisplatin plus VMAT 50.4 gray. Okay. And after the chemoradiotherapy evaluation, the endoscopy shows no change on the primary site, no recurrence in the primary site, and the biopsy was negative. And the CT scan shows a complete response in the cervical lymph node. So we go to move to the follow-up. And after 4 years and 6 months, the CT scan revealed the wall thickness of the primary site and the fistula formation for trachea. And the endoscopic biopsy shows a positive. So we think, but there no uptake for the primary site. Though he has the fistula formation, he can take normal orally, and no fever observed. And then, so what to do manage plan? So first, esophagectomy and chemotherapy, and the irradiation or stenting, and then. So. You experience the handful case clear trachea invasion. The surgery need to. Okay, would you see palliative stenting most part? Okay, but the palliative stenting is the majority opinion, but he can eat and he cannot have a fever. So how about this? The resectability. How do you think about the resectability for that cases, Simon? So.
Am I right in saying that there is clear evidence of a fistula now? Is that right? And biopsy proven. So I wouldn't do a esophagectomy. I would give chemotherapy.
Yeah. Okay. Thanks. So we starting the chemotherapy to palliative chemotherapy to reduce the progression of the cancer. So after the 5 course of the 5FU cisplatin, the tumor revealed a stable disease. But then after the 5 course of the chemotherapy, the primary tumor progressed and the dysphagia appeared. And the patient has aspiration pneumonia. But we started nivolumab as a second line chemotherapy from the 2021 January, and we are continue to the chemotherapy right now. Okay, this is a summary of my cases. Of course, that firstly, the T4 for the unresectable cases, the definitive chemoradiotherapy with the standard of care. Recently, the induction DCF is the candidate for such kind of the cases. And in Japan, we have conducted a phase 3 study for the T4OB cases compared to the standard of the chemoradiotherapy process induction DCF followed by chemoradiotherapy or the surgery for the resectable. If the patient go to resectable after the 3 course of DCF, the patient will undergo surgery. The phase 3 study is ongoing now. So, okay. So that is my cases. So,
well, very interesting, Ken. Well, we have well, we've just reached 9:30, but because I think these patients are so interesting, and we can spare a few minutes for some more discussion. Anyone want to make some comments? Christine?
Well, just thinking of your last slide, Ken, where you actually asked for nivolumab as a checkpoint inhibitor. Of course, that patient had a tracheal fistula. Chemotherapy on this situation, we wouldn't do this because we would be afraid actually of that pneumonia and any kind of bad conditions of the patients because of the fistula. Haven't you considered to put checkpoint inhibitors earlier because it's a squamous cell carcinoma?
Yes,
or is that not routine, or is it forbidden in Japan because you have guidelines and you have it only in the 2nd and 3rd place that you use checkpoint inhibitors for such a situation?
Yeah, the patient who had the fistula formation had a high risk of the pneumonia and the infection. For such kind of patient, the chemotherapy, for example, the paclitaxel or 5-FU and the cisplatin, which is have a adverse event to reduce the neutropenia, is a high risk for such kind of patient. So it is relatively the good indication rather of the nivolumab for such kind of patient rather than the so-called chemotherapy, I think. But the patient had the infection and the high degree of the CRP patient had not a good response even for the nivolumab, because nivolumab used to attack the cancers using the lymph node. But the patient had the CRP elevated, and is the lymphocyte already they have a less the function, but there is a less toxicity than the paclitaxel. I think the neuro is the preferred for the fistula formation patient.
I have to say that I agree with Christiane about the role of checkpoint inhibitors, and we have seen incredible response even in stage 4 patients, especially if a CPS score is elevated more than 10. And we have seen patients with stage 4 disease that get a complete response to their metastatic site, only site of disease, the esophagus, that we have taken for surgery in situation that we've never have expected or thought about in like 5-10 years prior. So I think this is a therapy that will definitely change the way that we treat this disease. A lot of it is still very unknown, but it's to come, and it's not very far.
Yeah, thank you. Yeah. I think the biomarker is a very, very important thing. So, but now, so only the CPS score is the useful biomarker for the esophageal cancer. So I was not check the CPS score this patient, but if the CPS shows more than 10, it is more preferable candidate for the checkpoint inhibitor. Thank you.
Daniela, you made a comment on the chat about if he achieves PCR, I would consider substernal conduit. What do you actually mean?
See, in a patient like this, if he responds to nivolumab in a way that you can really prove that he has a complete response to treatment, so the tumor is gone. Now this guy has got a fistula. His quality of life is going to be miserable. Okay. So in this situation, I would consider doing a bypass or partial resection, and he's got the fistula there, so it's going to be a tough situation. But for quality of life purposes, if you can prove that he has now a complete response, and it might happen with nivolumab, I have to say, it might happen. So you might have to consider that doing a bypass for improve, to let him eat and have a quality of life.
Yeah, sure. It's just like the first patient that I presented. We not commonly, but sometimes we do bypasses for cases like this. I have to say, I don't want to have all the attendees going away and thinking that this is a standard treatment for all. Okay. I think we have been super aggressive, Richard surgery and all these oligometastases, keep on resexing and nivolumab. I think certainly this is not ordinary. Most patients would not have survived all this long, the patients that we are presenting. I'm not sure what everyone thinks, but we are actually ultra aggressive here.
I think, Simon, the disclaimer is, I think, correct, but I think we are moving towards pushing the borders for those fit patients that you can offer a chance of cure. And in what we would do in a case with a close connection to the bronchus or the trachea, we would do an EBUS and see if there's ingrowth in the membranous part of the trachea, and then do an EBUS also after chemoradio. And in a lot of instances, the ingrowth disappears, and you can do a resection instead of waiting for a recurrence and a fistula to appear. So I think it's also a good message to be more aggressive.
I agree with you, Richard. Certainly, I mean, surgical techniques has improved, and all these radiation techniques, immunotherapy is improved. We are becoming more and more aggressive. But still, I think the majority of patients, when they present with diseases like this, very likely they have metastases and they are not fit enough for undergoing major surgery and so on. So, but I agree with you, we are pushing the boundaries here.
I think there was a question that was interesting from the chat, whether that I think is important to address, whether you will use 2 stents in a patient with a fistula. And I think that is, in my opinion, is very important to avoid placing stent on stent. I have seen really bad disaster with that approach where the all tissue in between completely disappears, and then you have a much bigger problem. So in my opinion, either only the esophagus or only the trachea, but never 2. I don't know if you guys have a different experience.
I agree with you completely. I think it's bad news. The trachea will disappear in between. Any other comments from anyone or any burning questions?
I was just, I would like just to comment on the Richard's statement to oligometastasis. I think it's, of course, and also all the cases that are presented here, we're pushing the borders, but most of all, when we do this in the way, even in a palliative situation or in a surgical situation, it is mostly case selection and case selection based on the biology. And this will be probably the future to select the right case to push the borders. And I think oligometastasis, Richard, and probably you would agree, is one area where we really, at the moment, with test of time and understanding the biology, try to find the right patients. And these cases can be pushed at the border, I think, not only the young ones, but also those which are biological safe or harmless, less harmful than others.
Fully agree.
Well, I think, we have overrun. I'm sure everyone wants to stay. You can discuss this forever. But then I think we have to leave somehow. Maybe I just comment those Q&As and chat questions that we haven't managed to answer. We will try to answer them after the event. You would be able to join a Facebook group on the ISDE site that will also put up this sort of video under ISDE later on. So you can see this slide here. So do become a member of ISDE, subscribe to YouTube and Facebook and Twitter and so on. Last, Richard, would you like to say some closing comments?
Yeah, I'd like to thank all the participants. I think we had about almost 200. There was a good discussion. Thank to the panelists. I think it was very interesting discussion, and also, of course, the presenters who gave us their interesting cases. I think it was a very nice international audience, and also I enjoyed the cases from early to very advanced. And Simon, thank you for organizing and making this happen. The idea also with the aid, of course, of Leah from the ISDE, who was very helpful also in the preparing of this very interesting tumor board. So thank you all.
Thank you. Thank you so much.
Bye-bye.